on the globalpalliativecare.org website. The webinars are uploaded on the WHPCA website, and I encourage you to go and watch them. We are very grateful to all the contributors to the series, and especially to today's presenters for accepting our invitation to participate in this collaborative project. This webinar will feature 5 10-minute presentations with time at the end for questions and answers. We will also have comments from Marcia Latanzi-Licht, who will share some reflections on today's topic. So please submit your questions through the chat box, and Shelley Innocent and Kate Jackson from the WHPCA will be condensing and reading them to the speakers, a wonderful way to participate in the webinar. And so today we're going to begin with our first speaker, but first of all to say that there are no conflicts of interest with our speakers, and we're going to be looking at interprofessional spiritual care with 3 presenters, Christina Puhalski, Marvin Delgado, and Rick Bauer. These webinars are based on briefing notes, and please go and read these briefing notes on globalpalliativecare.org. And the briefing notes were developed by a great variety of authors from around the world and from different faith groups. And we extend our sincere gratitude to everyone who has contributed to this briefing note on interprofessional spiritual care in the time of COVID-19. And so we go to our first speaker. The first speaker is Dr. Christina Puhalski, who heads the George Washington Institute for Spirituality and Healthcare at George Washington University, and who leads on the International Spiritual Care Education curriculum, and who is well known for her contributions and leadership in the field of spirituality and healthcare. So Christina, over to you.
So nice to join all of you this morning. I'll just go right to the next slide, please. So just as a summary of the main areas of the briefing note with regard to interprofessional spiritual care, one is to educate healthcare professionals, talk about how clinicians at the bedside should provide spiritual care, and then how spiritual care professionals provide care to patients and families. I will talk about the first 2 bullets. Dr. Delgado will talk about spiritual distress, and then Father Rick Bauer will talk about the 3rd bullet. Next slide, please. So in terms of suffering during COVID-19, we know that patients and families are experiencing severe spiritual suffering related to COVID-19. And healthcare providers also are distressed by the suffering and dying of their patients and by some of the challenges around resources and difficult treatment choices. And so not only are we talking about patients, but also in families, but also healthcare professionals in this pandemic. Next slide. So looking at spiritual suffering, which Dr. Delgado will go into more, I'm going to be talking very briefly about a consensus conference that occurred in 2009. And during that consensus conference, we used the spiritual distress diagnoses from the National Cancer Comprehensive Network, as well as some others that came up through that, that conference. And you can see, particularly with COVID-19, which is so devastating when one receives that diagnosis, that one of the first issues that people deal with in terms of suffering is questioning one's own mortality, or families questioning the mortality of their loved one. And healthcare professionals dealing with ongoing death and dying in the hospital. So this is a critical spiritual distress that has unfortunately not been attended to in many settings, which I'll go into a little bit more. Also, other existential issues, struggle with uncertainty is critical, despair, hopelessness, abandonment, isolation, etc. So next slide. When we think about people who are suffering in COVID or through any of our experiences with patients, one of the most important interventions we can do is to listen deeply and think about that this person is much more than their illness. I have had patients who were hospitalized and fortunately recovered who said we were just another COVID number in the hospital. And I think so much patients want to be seen and heard as who they really are. to be heard to what matters most for them, which for many cases with COVID is connection, needing family, and they're not able to have that. And then the why me, why now, and what's going to happen to me. Next slide. What Betty Farrell often talks about in her book as the silent screams. So when we think about the reality of clinical settings, this is something I found on the web, but the quote is from a colleague of mine when we were talking about spiritual care, emotional care. And he said, we don't have time to pay attention to anything except for the physical issues. It's life and death around here all the time. But I would postulate life and death brings so many need for that, particularly for that reason, to have spiritual care infused throughout the health setting. Next slide. And so we really need to think about, and although this was from images, not from the web, it so struck me, this particular image about presence, and that this is really the heart and soul of spiritual care. How can we be present to the suffering of others, particularly in a difficult time like COVID? Next slide. So, and then you can hit, so you just show the rest of the slide. So ISPEC is an interprofessional spiritual care education program that we've developed. It's national and international. We're now hosting our third one this coming July virtually. And the goal is to train clinicians, spiritual care professionals, and others to recognize and address the suffering of their patients, and including assessment, diagnosis, and treatment. So the basis of ISPEC is that all of us on the team address it, and we recognize the spiritual care professionals as the experts. And so for this conference, we often have had clinician chaplain pairs attend, and then they go back and implement goals and try to make changes in their healthcare setting. Next slide. Next. So, and again, next. Just a little history, don't want to go into it in great depth, but a long partnership with Fetzer in the City of Hope. Dr. Betty Farrell is the co-director of this course. Many of our faculty and attendees are from the Global Network for Spirituality and Health, and it's one of the first curricula at this level to offer interprofessional spiritual care in a global context. Next slide. So this is, no, back one. So this is a critical piece, if you can go back, yes. So this slide is really critical to the generalist specialist model and to many of the recommendations in the COVID briefing. So one is that we all assess, diagnose, and treat spiritual distress, and that is part of the symptom management, that we identify and support resources of strength if we can, and it's a generalist specialist model, which I will show shortly, and the provision of compassionate care, which I alluded to in the deep listening. It's being present to the other. Next slide. So in the diagram on the next slide, what you'll see is, and I can't point to it, but if you look on your left, there's spiritual screening on admission to the hospital, and then the patient and family meet the rest of us, and the history typically is done by those who do assessment and treatment plans, which would be physician assistants, nurse practitioners, and others, and then a full assessment is done by the board-certified trained chaplain. And then if we're fortunate to work in interdisciplinary teams, the chaplain again serves as the spiritual care expert. But all of us on the team have an obligation to ask and be present. And especially during COVID, where many chaplains were not allowed in the room, it's really important for the clinicians to be able to converse with and try to do some assessment and be present with the patient in the room. Next slide. So this is from the brief. You can see that in the brief, but we recommended that clinicians should do some sort of spiritual histories, for example, a FICA, offer presence, identify resources of strength, acknowledge grief, include beliefs and values and goals of care, which is critical, particularly in a crisis such as COVID, ensure dignity of patients, refer to spiritual care professionals, advocate for a peaceful death, and then provide respectful care of the body after death according to the person's religious and or cultural beliefs. Next slide. So I wanted to just very briefly, not going into the details of, this was a patient of mine who was hospitalized and fortunately did well, 86 years old, had moderate shortness of breath, high temperature, and a cough. So his FICA spiritual history, he was raised Catholic, very important in his life, feels very isolated right now from his family, church community. His suffering is so intense that, quote, even my prayer is not working. He's active in his church as a lector and a Eucharistic minister, and he would really like to receive the sacraments, see his wife, even though he knows he cannot, and would like someone just to sit with him. He's so scared. The complicating factor is that his wife has early dementia, and so he was so concerned about her and who would take care of her. And that was also a key part of this. Next slide. So in thinking about an assessment and plan, this is the types of things you try to encourage clinicians to do, to integrate it into their care plan. So again, briefly describing what's going on with this patient, what to do physically, emotionally, socially. The social worker was contacting family members to try to help the wife. And then spiritually, in this case, fear of dying, isolation, disconnection from family, wants to receive what he called last rites. And so we referred to a chaplain, and we wanted to see if it was possible for a priest to administer the sacraments for him. And that ended up not being possible. Fortunately, he got well, but we do have on our website a beautiful video of a priest that did go into a room of a dying patient and was able to administer the last rites. And the title of that is You Are Not Alone. And that's what spiritual care does at every level, is that connection, that even though your family's not here, we're here for you. Next slide. So we have a Train the Trainer program. It's an online Train the Trainer program where we work with institutions. Next slide. And I just wanted to give you a little bit of a description in the online course and also in the Train the Trainer with the background module, spiritual distress, compassionate presence, and then assessment and treatment, and ethics and professional development, which includes self-care. And so we are actually connected in this 1 hour, including the role of spirituality in our ability to care for ourselves. Next slide. So that was our first group, and it was pretty diverse. We had 23 different states, 12 different countries represented. Next slide. So we did evaluate this. I don't have time to go into all of it, but I wanted to show you because it was very interesting. In our evaluation of that first course, the modules that were completed 100% are those in the black on the small box there. Spiritual distress, communicating about issues and doing an assessment, and the whole person assessment and treatment plan. When we had our course, Module 6, Professional Development and Self-Care and Ethics was really high on the list, but actually people really wanted and utilized the more clinical aspect of interprofessional spiritual care in their settings. So even though the others were completed, but it was interesting to us. Next slide. I'm going to just very briefly, you can look at the bold because I know we have short time, but just some of the programs that people did, some of their goals that they implemented over the year, and we mentor people for a whole year. Palliative care fellows, some of them rotating with chaplains, many presentations. In Chile, they created what's called the spiritual accompaniment protocol, how to accompany patients in their hospices and palliative care units. And attend to their spiritual needs with compassion and presence, training, etc. Next slide. And then there have been some research projects I'm involved with the University of Indiana that we're currently just finishing the analysis of a pilot study looking at ISPEC in a pediatric hematology grant, an internal grant award, an internal grant was received for that. And then multiple sites looking at empowering nursing and social work, creating spiritual care databases, and then monthly sessions. Next slide. So I just wanted to close with the flyer from our course this year. It's July 6th to 7th, 2020. Registrations are still open. We have some limited but available scholarships from people from around the world. And this will be online. If you are interested, you can email my colleague, Dr. Christy Remen, at gwu.edu. And with that, thank you very much for your attention and for this brief introduction to this important topic. Thank you.
Thank you so much, Christina, for covering so much in such a short time, and also for your inspirational leadership in this field. And so we go on to our next speaker, and that is Dr. Marvin Delgado. He is from the MD Anderson Cancer Center in Houston, Texas, and he is part of the G-WISH group. He will be speaking on spiritual existential distress, a reality in the life of patients with advanced and terminal illness and of course with COVID-19. Thank you, Dr. Delgado.
Thank you very much for the opportunity. I'm very grateful for the invitation and honored to be here with you all. As Dr. Puchalski was telling you, one of the important aspects about spiritual care is the first part of recognition of the distress that people are experiencing living with advanced and terminal illness, and now obviously getting infected with this COVID-19 virus. So we're going to try to, in 10 minutes, just to try to describe a little bit about the impact of spirituality and religiosity, and mainly spiritual distress in patients with advanced and terminal illness, some of the outcomes research that we have, and some of the interventions that Father Rick will talk later on. Next slide, please. So very quickly, we're going to talk about a patient that I have on mind, Mr. HD with advanced illness, status post multiple treatments, with progressive illness and progressive deterioration and progressive poor performance status. On top of that, he just got diagnosed with COVID-19 infection. His widow, admitted to the hospital due to shortness of breath, worsening of pain, and severe fatigue and poor general well-being. He also had history of depression during the last 5 years, treated with citalopram and bupropion. And he used to live with one of his daughters. He had 2 daughters in total. Well, I was rounding with him in the middle of all these virtual visits and everything. I was asked, you know, after we talk about the physical aspect, I asked him, so how are you holding up with everything that is happening with you? How's your spirit doing? He looked at me and he says, the pain is horrible and I cannot stand it. I don't feel at peace and I can't stand myself. I guess I will die soon. Do you feel afraid of this? I said, yes, I'm very fearful about it. And my soul is hurting me. We have a scale that is called a spiritual pain, defined as pain deep in your soul that is not physical. 0 is nothing, 10 is the worst pain ever. It was interesting that he has been rating very high intensity of his spiritual pain. I said, tell me a little bit more about that, that pain that you're feeling in your soul. He looked at me and he says, I have sinned. My soul is bleeding. So definitely the reaction for me is like, there is no pills, there is no medication to calm down that suffering. And my main role as a clinician is to be present and accompany, try to help him to relieve that pain in the soul and that bleeding, you know. So he said to me, I asked him, so how can we help you with that? He says, pray for me. I want to confess and baptize, and maybe forgiveness. Next slide, please. So we continue to talk, and as we remember, we have patients that got the infection. Many times they experience a very advanced illness, advanced ages or very young ages, multiple comorbidities, many times cognitive impairments or presence of delirium that even difficults more the communication. At the same time, you know, many other physical symptoms, pain, fatigue, cachexia, gastrointestinal problems, shortness of breath for sure, and all the emotional and spiritual aspects also have been involved. On top of that, all the family and caregiver distress that is affected also. Next slide, please. And many times this is the reality, not only in cancer patients, but also in patients who have chronic, advanced, and debilitating illness, congestive heart failure, COPD, kidney disease, dementia, AIDS, you know, all those aspects definitely affected the physical, the emotional, and the spiritual. But the least that has been studied is the spiritual aspect, which continue to be evolved, and definitely we continue to study a little bit more. Next slide, please. So what we have to have in mind is that suffering is not a question which demands an answer. This is not a fixable thing quickly. It's not a problem which requires a solution. It is a mystery which demands a presence. And that's what we have to remember whenever we deal with these patients. Next slide, please. And patients suffer. They suffer having the preoccupation for whatever happened in the past or whatever is going to happen. And obviously they feel disconnected from themselves, from the others. They might have this crisis of meaning and a lack of control of their life at that moment that lead them to hopelessness, loss of social role. I'm not the one that I used to be. I'm not the father. I'm not the partner. I'm not the person that is used to help people around. They lost the sense of the independence. They feel meaningless and feel many times feeling a burden to others. Next slide. So one of the important aspects is there are different needs of the patient. Definitely there is informational needs, physical, emotional, social, and definitely the spiritual needs that patient might have in terms of hope, meaning, dignity, faith and religion, whatever is important to them. Next slide. We have to be able to recognize that despite that the spiritual needs in general are very prevalent in our population, very few ones are able to cover that need, that spiritual existential need. So it's important that we have to recognize that people want us to be part of that spiritual support. Many of them will say that they look for their family or for close friends, but at the same time, they will be looking for clergy, and many times will be looking for doctors to provide them spiritual support. So that is a call for us. Next slide, please. So we have to remember that is different diagnoses that we can have in terms of the spiritual distress at the time of existential abandonment of God, anger at God, concerns about relationship with the deity, or conflicted or challenged belief systems. There are many statements that we can have and think and connected with the diagnosis, like my life is meaningless, or I feel useless, I'm not sure if God is with me anymore. Or even for people who do not have any relationship with God or higher power, I have lost all the meaning in my life. That's kind of the distress, the spiritual distress that they might have. Next slide, please. So other diagnoses also, the feeling of despair, hopelessness, grief, guilt, the lack of reconciliation, feeling isolated, or if there is any specific religious distress that might be existing, and obviously expressing that spiritual or religious struggle. I can't pray anymore. What if all that I believe is not true? Next slide. So something important to remember is that the presence of spiritual pain is this unbalance in life. Next slide, please. It's a loss of being in relationships. It's that unbalance that exists whenever you become more aware of the death. There is loss of relationship, loss of self, loss of purpose, loss of control. While you're losing that life-affirming and transcending purpose of your life and of your own, and obviously the internal sense of control. Next slide. So one important aspect is that we study also that part, if the people with advanced illness were experiencing spiritual pain. And that is another important thing, because in our population, more than 40% of people were experiencing spiritual pain at the time of evaluation. And this is highly correlated with poor quality of life in general, poor the people are not able to cope in, not only in religious aspect, but also in the general coping, and also their beliefs might be less spiritual or less religious. Next slide, please. Another important aspect that we have to remember is that we can do this every day as a screening tool, just simply asking, do you experience or are you experiencing any spiritual pain or any spiritual distress? Because we have found that the presence of spiritual pain highly correlates with worse physical pain, worse depression, worse anxiety, worse drowsiness, and worse well-being, and even worse financial distress. Next slide. And the other important aspect is the family. Can we go back one? Family and caregivers also are very affected by everything. One more. More than 50% of caregivers with advanced illness experience spiritual pain also. And why is this? Because people who cares for people with advanced illness definitely experience that many tasks that they need to do many times they are not really having good communication with the healthcare, and they are facing the loss of their loved one. One important aspect also about the children also suffer, and many times we ignore that spiritual aspect that the kids are experiencing while their parents or their loved ones are sick, or whenever they are sick. Please, next slide. The other important aspect is that we have to work as a team. I call them the collective soul because each of us have their own spirituality, their own way to cope and deal with life in our own in our way to help people. But whenever we become a one single team to help people to improve the quality of life and decrease suffering, we become that collective soul. Next slide. So the other important thing is, next slide, please. We have to cover, from urgency, definitely all the physical aspect and the emotional, the existential aspect. The main goal is really to create that healing environment in which that is an environment of containment, or that we provide that culture of safety, a communication environment that is a culture of opening and attachment, where there is a culture of belonging, and obviously an agency that is a culture of empowerment and involvement and inclusion. So we work as a team. Next slide. And the other important thing is that as working as a team, we provide this integrative and integrative with multidisciplinary approaches, provide that touch of hope and touch of love to decrease suffering and definitely to improve the quality of life of patients and family and caregivers in distress. Next slide. Thank you very much.
Thank you so much, Dr. Delgado. I think you've really highlighted how important it is for all of us to be trained in spiritual assessment and care, and such beautiful slides as well. And so our next speaker is Father Rick Bauer, a Catholic priest, social worker, and board certified chaplain who has been living and working in Africa for the past 15 years and is presently in Nairobi, Kenya. Rick will be speaking today on the role of the professional chaplain in palliative care service provision during COVID-19. And I encourage you to carry on putting in your questions into the chat, please. I see many are coming through. Over to you, Father Rick.
Okay, and thank you so much. And it's always great to follow my good friends and colleagues, Christina and Marvin, because they just cover what every clinician on the team should be doing. And so what I want to jump into in just a few minutes is the role of the professional chaplain or the board certified chaplain. And just as the physician, the nurse, the pharmacist, you guys are experts in managing physical pain and physical symptoms. And the social workers and psychologists and counselors, they're the experts in mental health, cultural, social, and that emotional pain. It's the board certified or professional chaplain that, or the spiritual care professional, if you don't have that yet in your country. We are the experts on that in-depth assessment that Dr. Puchalski talked about, the intervention for spiritual and existential distress and pain, to develop the treatment plan that should go into the medical record. And so in countries where we have emerging expertise and experience in palliative care, every discipline needs to support the professional development and the accreditation of other disciplines. And I think this is being highlighted in COVID. I'm just working now with a friend and colleague in Guadalajara, Mexico, who doesn't have board certified chaplains, but is kind of training and bringing them on to meet this critical need. Next slide. So it's that professional chaplain, as my colleagues before me have talked about, we're the ones that are trained to listen, this deep, deep listening for spiritual needs and spiritual distress. We're the ones that are trained to accompany the patient, the family, the loved ones, and now, especially with COVID-19, accompanying the staff. This is so important because I know in where I did my training, hospitals in Manhattan, They were so overwhelmed by death, and people, nurses, physicians, residents that were not trained in palliative care were all of a sudden doing palliative and hospice care with the overwhelming influx of COVID patients. And so often our role then became really supporting staff. Every member of the team needs to screen for spiritual pain, but it's that board certified chaplain that'll develop the treatment plan. Some of the areas of assessment, if someone does come from a religious background, I want to understand not my spirituality or my beliefs, but the person's concept of God or deity or higher power. If they're not a believer, then what are your sources of hope and strength? Are there religious, as Christina mentioned in her example, are there religious practices or rituals that are important? And what is that link between religious, spiritual beliefs and your health? Next slide. So when I'm doing that assessment, I'm looking for that confusion or disruption about that person's meaning, purpose, connectedness. Those are the three words I just keep coming back to. And that can be connectedness to others, connectedness to God, a higher power, or some greater transcendence. We are really, in many palliative care situations, looking at wondering why. Why God? Why now? Questions about loss, grieving, and not only grieving the loss of life, but grieving the loss of financial stability, the loss of a job here in the slums in Nairobi, the loss of food security. People often lose previously held beliefs that worked for them. And this is a really important part why we need professional chaplains, not only community clergy, because often when people come into a crisis, the faith that they were raised in, they might have been raised a Catholic, but those beliefs don't work for them anymore. And so my role is to assess and accompany and find beliefs that will work. Looking at feelings of being, unworthy, damaged, punished, and then forgiveness and reconciliation are key areas for treatment plans with spiritual distress. Next slide. And so in COVID-19, it has turned upside down what we as palliative care chaplains used to do. We have gone from touch to no touch. And in some hospitals, because of the lack of PPE, we couldn't even get into the room. And we were having to do from visits to phone calls, from being present that Christina talked about, to this virtual presence. We used to encourage families to keep vigils, to be present with their family as they breathe that last breath. And we had rituals for that transition. And now loved ones are often outside, sometimes not even allowed in the hospital while the loved one is dying in an ICU. I worked with my colleagues doing some virtual spiritual support in Manhattan, and this question of where is God and why is God doing this? Why is this happening? We're having to do modified rituals and funerals here in Kenya and elsewhere. Overwhelming moral injury when, I just talked to a colleague that they had to make anybody over 50 immediately goes to hospice. There is no treatment because the health system is so overwhelmed. And how does that health worker make that situation? We're dealing with fears. And a lot, as I said, of the staff support is trying to make sense out of the suffering and this dissonance. So many healthcare workers, they love caring for patients, they want to care for patients, and yet they themselves have this self-preservation and afraid of getting infected or getting infected and infecting their loved ones and family, and then feeling guilt for self-concern. So COVID is bringing up some deep, deep spiritual issues. And I'll just end with the next slide. If you're interested in some great research on spiritual care and what do palliative care chaplains do, a great article by Julian and Fitchett and colleagues, and two great articles on the state of the science of spirituality and palliative care research, screening, assessment, interventions, definitions, measurements. Two great articles. If you're interested, let me know and I can help that. Asante sana, thank you.
Thank you so much, Rick. And thank you for actually leading here in Africa on developing chaplaincy in palliative care. And so I hand over to Stephen and say thank you to all my panelists for keeping to time so beautifully.
Thanks very much, Joan, and thanks to the panelists. Great presentations on spiritual care. It's a really key issue right now. I think spirituality has come to the foreground during this particularly difficult time during the pandemic. I'm Stephen Connor, and I'll be moderating the second half of the session today, which is going to be about self-care for caregivers during the COVID-19 pandemic. As we said before, we have briefing notes for these different topics. This one is available on the announcement for the webinar series. Is a link to where you can go to the to get those. But if you need that link, let us know. And the authors of this particular briefing note include Dr. Dale Larson from Santa Clara University, who's going to be our first presenter on this topic. He is the author of The Helper's Journey, Empathy, Compassion, and the Challenge of Caring. He's going to speak now on personal self-care and stress management. Over to you, Dale.
Thank you, Stephen, and thank you for that great presentation by Marvin, Christina, and Father Rick. Yes, that was just exquisite and really set the stage for talking about self-care. And what we have to do now is kind of turn our focus toward ourselves and think about, well, how are we experiencing some of these things and what can we do about that? Because I think we have spiritual distress, and our spiritual selves are one of the greatest resources we have in dealing with what we're trying to confront in caring for COVID patients. You know, I don't think I need to make a case for self-care. I think we're all very aware of the need for a greater emphasis on self-care. This is a photo of an Italian physician who's obviously pretty stressed. We know from the recent research that's happening about that there's tremendous stress in doing this work. A study in Italy showed that 50% of the healthcare workers reported PTSD symptoms. In China, 70% of the healthcare workers report high levels of distress. We've seen it in our colleagues. We know that this is a time when we really need to give more attention to ourselves and turn that caring kind of focus that we've been hearing about already today toward ourselves. Next slide, please. So we've seen, one more click, the impact of this on bereavement, on us as caregivers, the social distancing, the self-quarantining, the isolation, the separation, the inability to be present, which I think was just beautifully highlighted in the previous talks, how this stresses us and how this keeps us from doing what we've been doing forever in our caregiving. You know, I really think that the COVID, this novel coronavirus, has really created a novel form of traumatic bereavement that we're going to be dealing with for a long time. But it also has so it's derailed normal processes of grieving and mourning that we've just heard about. But it's also undermined all our self-care because we're not able to get the kind of social support that we could in the past. In every way, a lot of the self-care practices that we have had in place for ourselves are undermined and are really affected. So it's especially important that we turn our attention to focused self-care. Next slide, please. So if we think about self-care and we think about how we can mitigate the effects of stress and working with trauma. One of the strongest finding in all the social sciences is that we have to strengthen our social support. I don't think this is news to anyone, but it is so important that we reach out at this time and we overcome any kind of resistance we have to doing that. We don't have time, maybe. We say nobody else is really going to have the energy to support us, but we need to reach out and get more support for ourselves. This is something we need to do when we have a lot of stress. It's ancestral plane behavior, if you will. We need to reach out, and that is one of the best moderators of stress that we can possibly have. And we get that support from colleagues. I think the focus on interprofessional support that we were just hearing about and communication is essential. So that can be in the form of good supervision, or it can be in the where you can get technical appreciation, technical challenge. It can also be anyone in your life with just the big ear that you can always have to go to. We really have to get that in place. I think one of the things I want to say is that we need to build in these self-care practices. And, you know, even before I go on, I want to say that there is no single bullet, no magic bullet for all of us, but there possibly is one or more for you. And what you have to do is do some inner Googling and say, what's been working for me? What works at this moment in terms of self-care? We all have things that we find, well, make a difference. So when you can identify those things, that's what you really need to focus on. Resilience is not a trait, it is an outcome. And what the great news is, we found that these kind of stress management practices and self-care practices can really make a huge difference in terms of that outcome. So we can strengthen our resilience. We all know we have to maintain good health habits. We have to get our sleep. We have to get good nutrition. All this becomes more difficult when we're in such a stressful situation. And to practice mindfulness and relaxation, we've all been hearing about mindfulness. We need to practice it in our daily work because it's a great buffer for stress. It allows us to get a little separation from these strong emotions. It also helps us in our direct care of patients so that we can have that kind of presence that Marvin and Christine and Rick were talking about with our patients. So we don't fall into what I call the helper's pit. Next slide. So the critical thing is to take action, to take control. And you might say, well, I just don't have a lot of control over these situations. You know, we've all heard this forever, you know, Reinhold Niebuhr's Serenity Prayer, and it's always important to emphasize it. It's in every stress management book. God, give me the serenity to accept what cannot be changed, courage to change what should be changed, and the wisdom to distinguish the one from the other. We have to sort out what is we can change, what we can't change. We try to intervene more upstream in terms of self-care to change the situation if we can, problem-focused kind of coping, the way Dick Lazarus, my teacher at Berkeley, talked about it. And then when we can't change that, we need to intervene with how we're appraising things. We need to intervene with all the other modifiers like social support and the other things that can make a huge difference. And then farther downstream, when all those stress hormones are coursing through our veins, we can exercise and try to get some of those hormones out of our system, the catecholamines and all that are piling up. We need to take breaks and set limits. Not easy to do. I know some of you are going, oh my gosh, I can't possibly set any limits now. But we do have to do that for ourselves, especially when we're overwhelmed. We need to compartmentalize, which is really hard to do when we're doing this kind of telemedicine or we're sitting at home. That's a very complicated situation when we don't have this separation of work and our lives. So we need to focus on that. We need to find ways to compartmentalize a bit. You know, one chaplain shared that, you know, for him, it was that the grief was pouring out of his computer into his home. And I think that that's something all of us who are working at home, I see bereaved clients from this very seat I'm sitting in now. It's a little tough at times because I have a life outside this room. Maintain a schedule and a structure at home is very important because we're in this situation where Our usual structure is not there. We're not going in somewhere. We're not seeing patients the way we used to. We need to build in a structure so our life has some pattern to it, and that can really help in terms of self-care. Next slide, please. So, as they say, practice the art of the possible. Realize that doing something a little bit is a lot. And be flexible in coping. This is one of the findings in the research on stress management, that we need to be flexible. We need to see what's working. It's the same thing with coping with bereavement. We know from that research that flexibility is key. And be kind to ourselves. We have to, in these difficult times, have compassion with ourselves. We have to understand that not everything's going to be perfect. We're going to struggle at times. We're going to have maybe some anger at things. We're going to have difficult feelings. We're going to maybe not have the best situation every moment of every day. And to not turn to ourselves, to understand that we're in a really difficult situation. This is very often an overwhelming situation. And burnout doesn't result from bad apples. It results from the bad kegs that the apples are in. And today with COVID, most of us are in a pretty bad keg in terms of the amount of stress and the demands that are placed on us. Next slide, please. So, you know, if we could bottle exercise, we could have and sell it, we could have enough money to provide quality palliative care to all the people on the planet. Exercise comes out in all the research as one of the best things we can do, and any kind of movement really helps. So even gardening, walking, aerobic exercise is fantastic. Bicycling, and I know it's hard, and I don't know what all our situations are. Sometimes it's very difficult to do. Find a way to get some exercise. Also, we're all strapped into our chairs Zooming at these days, those of us who are working in telemedicine and things. You really need to do this for yourself, because it burns up those stress hormones and can really make a huge difference, strengthening our resilience and giving us vigor to counteract the exhaustion that's the hallmark of burnout. Next slide, please. So one of the big challenges, and I want to end with these thoughts, that we are confronting suffering, and that's an adaptational challenge, being exposed to such mortality, trauma, often overwhelming tragedy. And the thing we have to do is first acknowledge their presence, as part of the work you do. Find these supportive colleagues to talk to about these experiences, so we overcome the fallacy of uniqueness. Attend to these losses so we can integrate them and transform them. That's the real work we have to be engaged in. And then this work can really truly be, as we all know, a real source of growth for us. Next slide, please. And one of the findings is, and this is actually a photo, it's not coming through, of Albert Schweitzer, is to find meaning in this work, which, as one physician friend said, there's a lot of meaning in this work, I just don't have time to find it. But Schweitzer said, I don't know what your destiny will be, but one thing I know, the only ones among you who will be truly happy are those who will have sought and found how to serve. And one of the things that's becoming really clear, and it's just the most fascinating area of research, and I think this is something we all know in our hearts, is that it's becoming clear that connecting to real purpose in our lives, this is something that I think in the spiritual distress assessment, we're helping patients discover purpose and meaning in their lives. But committing ourselves to something beyond ourselves and our own needs provides a tremendous buffer against stress, and it can carry us forward in the most difficult of times. So part of self-care is realizing the significance of the work you're doing. And I want to thank you for all that you do. And I'll end there. Thank you.
Thank you very much, Neil. That's really important to understand that we all have different ways that we can manage our stress and take care of ourselves. And it's really, as you say, oftentimes a journey that we have to customize the way we deal with it. And it overlaps in some respects with spiritual care, that the meaning making is so important to coping with difficult times. Now we're going to go to our final panelist, who is Professor Mary Bashan from the University of Toronto. Also, quite a while ago, was the author of the original book, Occupational Stress and the Care of the Critically Ill, Dying, and Bereaved. Mary is a longtime worker in palliative care, psychotherapist, a former cancer patient. She's a remarkable woman. And I invite you, Mary, to take the floor and give us your presentation on the organizational aspects.
Thanks, Stephen, and it's such an honor to be involved with such great panelists. Dale and I go back many, many years, as do Stephen and I did a retreat with Christina many years ago, and nice to virtually meet Marvin and Father Rick online. And like Dale, I'm primarily a clinician working from home at this point remotely. So in preparing my comments today to make sure I really had a sense of what was going on the ground, I turned to, I'm just trying to see if I can do my video. So I turned to a variety of people for help so that I could have some practical on the ground help. So the, can you go back to the previous slide, Steve? So I spoke with a variety of people, including Dee Dee Suslak, my sister-in-law, who is the head of infection control at Mass General. Through Doctors Frank Ferris and Charles von Gunten, I got introduced to Dr. Kate Dean-Haydett at the Integrative, who's the Integrative Mental Health, APP, at the Ohio Hospice and Palliative Care Center. My long-term friend, Dr. Deb Mayer, who's a distinguished professor of nursing at the University of North Carolina, was helpful, as was Val Masdorp, who is involved with the Island Hospital in Zimbabwe, which some of us are supposed to be visiting next week, but we won't be, unfortunately, and my colleagues, Dr. John Hunter and Bob Mondar in the Department of Psychiatry at U of T. So recently, there was an important article in July by Schoenefeld and his colleagues, and he's done an incredible amount of work in regard to occupational stress. And they surveyed 69 clinicians during the first week of treatment of COVID, and found that what these people said they needed was hear me, protect me, prepare me, and support me. This was a new disease. People were struggling. They were learning second by second. People did not have a clue why the approaches that previously worked so well weren't working. And so the staff needed to feel that they were being heard. They needed to feel that administration was listening to them, listening to their needs, attempting to meet their needs through virtual town hall meetings, suggestion boxes. They needed to be prepared. Staff working in a medical setting could be suddenly transported into ICU. People working in recovery rooms were suddenly transported into ICUs. They didn't know how to use the equipment, and having a buddy system was really helpful. There needed to be recognition. There needs to be recognition that lots of times we don't know exactly what we're going to be entering into and what we can do to be most helpful. And supervisors need to understand this. One person I was talking to was talking about now what's going to happen as people are being transitioned from the acute care hospital into palliative care with COVID, and all the family members are positive. How are caregivers going to be giving this kind of help? And there's going to need to be patience and recognition that this is a new learning situation for everyone. Psychiatric colleagues are embedding themselves with teams so that they can provide ongoing help for the patients, but also for the staff. So consultation liaison psychiatrists, spiritual care practitioners are sometimes embedding into teams. And in Zimbabwe, the Island Hospital people found that they are now seen as the experts. So they're going out to quarantine centers, government hospitals, and helping people work with developing resilience, doing training programs, and dealing with loss and grief. Many organizations are providing newsletters because we need to be prepared for the physical work. We need to be prepared for intellectually. What is this experience like? We need to be prepared emotionally. So the newsletters have things like what happens in a disaster, and the fact that this is an ongoing issue that is going to be with us for a long period of time. These newsletters provide links to meditation, yoga. One of the important ones that I saw recently was from George Washington, providing a link to lots of articles on racism, because dealing with racism in this time of COVID is a huge issue. And we need to be able to monitor demands on the caregivers in order to permit essential self-care. One of the issues is it's addictive to be in this kind of work. It's addictive to be with your friends and colleagues at work, but there are problems if you don't manage to get some breaks, some time off. One of the issues is the kinds of getting together that used to be just fine are a real issue. So, for example, in one setting, 2 outbreaks of staff came from staff sharing, being in the staff lunchroom together, and COVID was spread in this way. One of the newsletters provided information about something called moral fatigue. We're making constant moral decisions at every moment of our lives. And one of the moral decisions we need to have is not to come to work if we're feeling ill. The next slide, please, Stephen. So the issue of workplace hygiene and PPEs is a huge issue. Staff are being provided, sometimes they're not being provided with equipment, and we all know the problems. When there is equipment, there are videos showing how to don and doff, put your gowns and PPEs on, how to take them off. When staff members get COVID, there are, in some institutions, very careful looking at how the person donned and doffed, and are there things to be learned during this time. And one of the centers showed visually on a video what happens with spread of COVID particles, depending on the kind of mask that you're using. Staff need to be helped with being able to have safe sheltering and quarantining. And so this is sometimes going to mean staff need to be housed away from their setting and away from their family in order to not be bringing it back home. We need to recognize that, from what I've heard recently, the 2 groups most likely to break quarantine are adolescents and healthcare providers. This is a really important insight, and we're not necessarily being careful enough. One of the suggestions made was having a way of getting home if you're sleep deprived, so having some kind of drivers provided. Providers need to be assisted with their family responsibilities, such as daycare for caregivers and even issues like elder care. The next slide, please. Many of us need to be taught this direct telemedicine training. And I took a course as soon as I started going on. And one of the things I was told was you have to have a whole variety of backups. So if the Zoom doesn't work, what's the phone number to get you at? How do you work with all of this? Many people are finding it very challenging to be spending their time doing all their work virtually. I find it's helpful to be switching back and forth between Zoom and the platform I'm using and the phone. And having caregivers get together as teams. One of the things that's being done in at Ohio are resilience groups where staff get together and are able to, these are restorative peer support groups. And so they start with meditation, then sharing their insights about their present state of being, have support from one another about what's going on, and finish with a final blessing or concluding thought. And these are done virtually. Sometimes people are using phones to touch base. One of the comments that Val Masdop from Zimbabwe made was that she was finding staff were touching base with one another a lot more than usual. We need to find meaning making. And Dale commented about this and the important work of Lazarus. Colleagues of mine, Doctors John Hunter and Bob Mondauer at Mount Sinai in Toronto, had been through SARS, and they provided a whiteboard, which is a whiteboard lecture, which is available on YouTube, talking about ways of coping and the importance of meaning making, recognizing it's a privilege to be able to serve in this kind of work. The next slide, please. Mental health is extremely important, so the embedding of psychosocial people, spiritual people in the teams is helpful. Some organizations have warm lines so that caregivers can call during the day and get help, and hotlines, which are 24-hour caregiving lines that can be monitored. The VA hospital has a COVID coach, which can be created for everybody, which has education about coping with the pandemic, tools for self-care to improve emotional well-being, trackers to trace your mood and measure your growth towards personal goals, and graphs to visualize your progress over time. These also have standardized tools, which can really be important. We need to carefully monitor staff returning from being ill with COVID-19, particularly if they've been on ICUs. They may be having PTSD experiences. We found in Toronto people who had been hospitalized, caregivers who were hospitalized with SARS, were then hesitant to be treating people with COVID. There's the well-publicized case of the physician who committed suicide after being having COVID, returning to work and being put on leave. We need to recognize we don't know the problems people are going to be coming back with. We need to recognize that there's going to need to be a lot of work done, a lot of support available for staff needed after the pandemic. And it's going to be important to look how much of this can be provided by people outside the system, and how much is the credibility going to come from people who've been through the process together. We need to recognize the bereavement needs people are going to have, and to mitigate the stigma at the community level for health providers. We need to educate healthcare providers about the fact that yes, there are going to be challenges here. We need to try to reassure people we're doing what we can. So I now look forward to our ongoing discussion, and thank you for the privilege of being involved with all of you today. And thank you for the wonderful work you're all doing all around the world in this time of incredible crisis and change. So much wisdom and compassion are being shown.
Thanks very much, Mary. It's so important. I mean, burnout does come more from the kind of work environments we live in than our own limitations. So thank you very much for that. We have one final speaker today. This is Marcia Latanzi-Glick, an old friend, who will be giving our reflection on the presentations just briefly before we go to questions and answers. Marcia is a psychotherapist, educator, and consultant, person with lived experience of loss, and has been in the field since the mid-70s and is a very wise woman. So Marcia, over to you. Be sure to unmute yourself.
I did it.
Good.
Okay, thank you, Stephen, and thank you all for these wonderful presentations. As I was listening and reflecting on things people said, I came up with a number of things that I think are bridges between these two topics, and so I'd like to just offer them to you along with some thoughts. First and foremost, the whole experience of COVID is unique because there are so many multiple layers of loss that are involved with people. The loss of the predictable, the loss of our everyday known world, all the things that we look to for comfort, as people have pointed out so adequately. One of my clients said, I wonder if I'll ever see my grandchildren again. And there is a sense of special moments of our lives, one and only moments that may never come back again. The second area I was thinking about is this whole notion of connection and how we are connected to each other, to the people we work with, to our peers, and also to ourselves. And what I have seen is that many of us have lost our deeper connection with ourselves just from the layers of distress we are experiencing. And what we bring to the situations of our lives is our sense of connection to ourselves, as the spiritual care providers spoke about so well today. The third point is the notion that there is a sense of meaning that is in both spiritual care and in self-care. And meaning in times of crisis is always difficult. Our longing for it is heightened, and we search for a different source of meaning, or a deeper source of meaning, perhaps. And I think if we look back to the original work of Viktor Frankl in after his experience in Auschwitz, he pointed out that survival is a collective act. And we need to remember that we don't survive just on our own. We do this with our connections with each other, with our support from each other. So I'd like to just speak about the whole notion of connections for a brief moment. And that is how we have heard from everyone the importance of social support. And yet it seems, we know this from all our research, it seems also that this is the area where we are experiencing the greatest disruption, the whole notion of our connections with each other, the time we have available to spend together, and as Dale pointed out, social distancing, isolation. And for most people I have worked with, there seems to be almost a sense of withdrawal that accompanies some of the distress we are experiencing. So the connections, a sense that we are not alone, is critical, not just for the people we care for, but for ourselves. There seems to be another dimension about COVID that is rather unique, in that even more than people who are dealing with end-stage illnesses, the unknown is a profound dimension of this time. So we're looking at when will this end? How will the future be? When will we be able to resume a different type of normal activity? So that sense of the unknown is really, and a sense of time is really questioned. And both of those are important existential spiritual concerns. Finally, the need for all that we know in hospice and palliative care, our skills, our knowledge, our principles, everyone needs them at this time. So how can we make sure, and we made a point of this in the briefing, how can we make sure those skills are made available to people in the greatest way possible? Because that, in fact, then helps us all be stronger and better in the work we do. And I want to echo what we all have experienced here today, and that is my deep gratitude for the wonderful work you do, and wish you well and strength in your days ahead.
Thank you very much, Marcia. Appreciate those reflections, and kind of putting the whole presentation together into a whole, coherent whole. We're going to go to questions and answers now, and I'd like to invite Kate Franklin to bring forward the first questions. We're not going to probably be able to respond to raised hands in this setting, so please do put your questions in chat. We'll get to all of them, but we'll do our best. Kate.
Thanks very much, Stephen. Thank you. And thank you very much for the excellent presentations. Really fascinating. The first question is, how does one conduct a spiritual assessment in a heavily sedated or unconscious patient in the ICU? Do unconscious patients no longer have existential suffering and spiritual distress simply because they lose consciousness?
Maybe I'll answer that first. I think that came from one of my colleagues at Children's Hospital. What I put in the chat box, and it's maybe not the most ideal way, but try to understand what the spiritual history might be of the patient, either from family members or others, or ideally, if as we begin to do this more and more, we can look in the chart to see what the primary care physician or provider found out about the patient. And while it's not ideal in the exact moment as that person is laying in the ICU and unconscious, it at least helps frame a little bit of our understanding, much as we do with other things when we try to find out from family and primary care professionals about the patient. I think connected to that would be being present and trying to at least provide that care and recognition to that patient. Many of my patients who've been in that situation have remembered pieces of what was going on within them while they were unconscious when they recovered, and also remembered touch and presence. So I think, maybe that's not a full answer, but that's where I would start. Thank you.
Thanks very much. Does anyone else have anything to add to this question?
Let's go on.
Sure. So the next question is also for Dr. Pachalski. What were the spiritual care guidelines before COVID-19, and have they now changed?
So the original guideline probably was in the early 2000s when the National Consensus Project wrote that everybody should get, all patients should have a spiritual assessment, but there was no direction as to who, what, where, and how to do that. So Dr. Betty Farrell and I convened a group in the United States of palliative care professionals, as well as clergy, chaplains, psychologists, PT, OT, et cetera. It was a very diverse group to try to build on that guideline. And that's where we came up with the guidelines of the interprofessional model that I presented. Since then, the National Consensus Project has built Domain 5 is the domain that requires a religious, spiritual, and existential care, and has integrated those guidelines into Domain 5. And then subsequent to that, there have been other guidelines in other countries as well, EAPC in Australia and many other places on spiritual care, some building on similar work to ours and integrating other work as well. So that's briefly the history of the guidelines. And then finally, the WHA passed a resolution on palliative care, where at least there is a recognition to integrate attention to spiritual pain and distress, as well as psychosocial and physical, and also the ethical obligation that all clinicians have to attend to all of that suffering.
Thank you very much. The next question is also for you, so I'll just continue. How do we assess for spiritual pain if we are not a chaplain?
Right. So it depends on. I'm going to speak now to the professionals that do the assessment and treatment plan. So doing a spiritual history in that context, that's not a yes/no type of FICA is not a yes/no type of tool. No other histories that are being used. It's a conversation with the patient and inquiry. So the idea is in your conversation with the patient about their spirituality. Perhaps you will, depending on how good, whether it's a well visit or a crisis, you will assess further if you hear themes like hopelessness, lack of meaning, despair, etc. And I actually use that for myself as a review of systems for spiritual distress to inquire about those. Once I found out that the person identifies as being spiritual, you can further explore in the conversation with the patient whether they're experiencing distress and what type of distress that might be. It is ideal to be able to work with a chaplain. There have been many times when I thought it was one type of distress, and actually working with a board certified chaplain, found out we have an interdisciplinary team for our supportive and palliative care clinic that found out that perhaps that was not the correct distress, but at least when clinicians come up with that, it's just like anything else that we do that's not necessarily directly in our specialty. We have an idea of what the distress might be. We attend to it, at least listen to the suffering. And this gets a little complicated, but with deep suffering, it's not as physical pain where one can prescribe a medication. It's not really fixable. But our presence and our listening to the patient and helping them talk about it also helps us as we listen without interrupting to the patient what type of spiritual distress they might be experiencing.
Thank you very much.
You have a saying, increasing morphine will not remove spiritual distress. So.
Probably not. Maybe an awareness at the moment, but no, probably will not. And I think that's what's critical. You know, so much of our training is to intervene quickly. That was that comment from my colleague, if we have to deal with the physical. But if the person is having deep spiritual distress, you know, and emotional distress, we have to deal with that as well.
Okay.
Thank you very much. I'll open the next question up to the full panel. What are some practical ways of ministering to people when you are in full PPE?
Probably
No one else is going to take that. I would really encourage you to send. I'm happy to send that video of the priest/chaplain that did minister to a patient while he was in full PPE. And it's very, very powerful. So what I would say to that is, and even that picture that I showed while off Google Images, the connection that one can still establish a connection with, quote, barriers, the full PPE, or being distant a little bit physically from the patient. And that moves to that area of development within us of how do we express that deep compassion. And maybe my colleagues can elaborate on that a little bit more.
I mean, I think it's naming it, you know, that, oh my gosh, this is just really weird that I have a face mask, I have goggles, I have gloves, I have all of this on. I know this is really hard, but I really want to be here for you. And this is a strange disease. And so whether it's COVID and PPE or any situation, when something weird is going on in the room, you know, like there's an elephant in the room and no one's talking about it, name the elephant. This is really hard, but I want to be here with you.
And I believe also that definitely, even if you have all the PPE on you and you want to provide that spiritual care, your presence, being able to share that journey that the patient is living, you know, talking with them and kind of listen to them also, that is one of the major parts that we can do as a spiritual cares. And obviously we are providing also, you know, the full care, just integrating the family, using the video calls and everything. That is a great thing also, that I have had a great experience that we create a kind of sacred moments, even with video calls and me in PPE and everybody. So I think it's important not to block ourselves, that we won't be able to do the best care for our patients who are suffering and needing having the PPE. So I think it's something that we can do it if, definitely it's a different way, but we can really help the healing process of the patient.
We've also seen clinicians take a photograph of themselves without a normal photograph and attach it to their protective suit, so you get a sense of that's a real person here. Kate, you want to come forward? Another question?
Thanks very much. The next question is a personal one from someone saying, as a palliative care doctor, delivering face-to-face end-of-life care, but living away from home to shield my extremely vulnerable son, do you have any practical suggestions for self-care as this is becoming a long-term situation?
Do you want to address that?
Well, I think this exemplifies some of the incredibly stressful situations we're thrown into. We're cut off from our families, and we're afraid of infecting them, and that adds to our stress tremendously. This is one of the unique factors here. It's not exclusive to COVID, but it's extreme in COVID. And again, I think I think disclosure is very good, like Marvin saying, and Rick and everyone. In these situations, we have to really, when in trouble, disclose on the doubles. Say, this is really hard for me, and to continue to reach out in every possible way we can. I think we have to get creative and try to bridge those distances, just as we're doing with patients. We have to find a way to establish presence. We have to do that with our family and communicate our love. and love can kind of carry us through. I think that that's the real challenge here. We have to actively do things that before were a little bit easier because we were present and we were able to physically present. I don't know, Mary, if you have something to add to that, or Marcia.
Well, I think there are not easy answers to this kind of a question. And I guess one of the questions is there some way safely, if you're sure you are COVID negative, to go and spend some time with family so you're actually getting out of the situation? Because we do need some breaks, and we can so addictively feel we are the only one to handle the situation, and yet there are times when someone else needs to take over, and we need to do some things to feed our own souls and nurture our own family. We're feeding our souls with the work we're doing, but I think we also need to be conscious that we need to spend some time with our family, because we're asking an awful lot of them by always understanding our needs.
I think we also need to remember that so much of human communication is nonverbal, and that we're saying with our bodies and our ways of being, how we care about people, maybe how we're afraid. We communicate so much. So let's make sure we really approach people in whatever ways we can.
Thanks very much. The next question is about spirituality in children. The first question was, how does spiritual care differ from children versus adults? And what are some of the spiritual issues children experience? And then we've got another question that's asking specifically about how to assess or discuss spirituality with older children or teenagers with life-limiting conditions.
I believe that one of the major special differences between the adults and the kids is that we have to recognize as the medications doses are different. Definitely the way that they might cope is different, and we have to also know about that there are different development process that the kid might be having, and that includes obviously from kids to teenagers and early adults. So all those aspects we have to have in mind, because maybe the spirituality for kids might be their relationship with their superheroes, and that's one of the major things, but at the same time obviously what the parents are showing that part. So we have to recognize that part. But the very important thing is that knowing the developmental level that the kid is having, it's good to talk with them, because I had a patient that it was 8 years old, very mature kid, and whenever I asked him about how's your spirit doing, he answered me, I'm doing okay and God is with me. I just want my daddy and mommy to be okay and not to cry for me. So those moments, I was shocked. It's just like we get surprised, with that precious moment that the kids might have. But if we don't ask, or at least we don't intend to ask, that relationship might be lost, and we are not able to kind of explore if the kid is suffering in certain ways. So I think it's important knowing the levels of development that the kid might have. Definitely, that's another important thing about the emotional and the spiritual aspect of the kids. Teenagers, obviously, they have their own development level. So that's another important thing to explore, where they are, what is important to them, is even what started giving them some meaning, in what is in their life. So questions, open-ended questions always will be great for them.
I totally agree, and I think this is a great impetus for this group that we need a session on pediatric spirituality. Joan, let's do it.
Absolutely.
And I think just to add to what Marvin said about the developmental issues, the language is different, and children use play and art, and you got to get down on the floor, and if you're in Africa, you need some drums and musical instruments to get the child. I often am when I do the meaning, purpose, and connectedness, especially with younger kids, often a lot of connectedness. The other issue that can get really tense is sometimes the child's spirituality is different than the parents, and the parents think that the child is just like them, which creates some really interesting ways to do person-centered spiritual care with children. But I think absolutely children are deeply spiritual, and this needs to be screened, history and assessment, just as we do with adults, but with different tools.
Yeah. And maybe I can just add that we have a poetry group, and the children really express their spiritual needs and concerns through their poetry.
Julia?
Perhaps, Kate, I can just add, hi, it's Julia here from the International Children's Palliative Care Network. It always amazes me how much children understand and how they can talk about their spirituality, maybe not using the term spirituality in the young children, but how much they understand about what is going on. And how, if you ask them and look at different ways of exploring those issues with them, as Father Rick said, then there's so much that you can learn. And it's really important that we have that understanding of some of the different developmental stages within children, and what they might understand and what their expression and experiences around spirituality might be. But it's so important that we do consider it and pay attention to it.
Well, great. Excellent comments. Good questions. We're going to begin wrapping up now. I want to mention that the slides that we have for this presentation, as well as the webinar recording itself, will be available afterwards on the WHPCA website in the COVID-19 section for webinars. We are going to have our next session 1 week from today, Thursday, the 18th of June, at this time, on the role of telemedicine in delivering palliative care during the COVID-19 pandemic. Another very interesting topic for us. Would you all please join me in thanking our presenters for today, Christina, Father Rick, Marvin, Dale, Mary, and Marcia. We really appreciated your presentations today. They were excellent. And on behalf of the WHPCA, the ICPCN, the IHPC, and PalChase, we want to thank you for joining us today, and hope you all stayed well, wash your hands regularly, and take care of yourselves. God bless.